Hello everyone and welcome to our fourth webinar in our 5-part series titled The Honesty Sessions. It is 7 o'clock. I'll just wait for a few more people to arrive and then we'll make a start. So I can see that people are now kind of coming into the session. So welcome everybody. Just let the numbers let everyone get in, find a seat, and then I'll make a start. So as I said, welcome everyone to the fourth webinar in our 5-part series called The Honesty Sessions. I'm Vicky, I'm a member of the 99 NICU team who has been working alongside Lauren from the Adult Preemie Advocacy Network to organise this, although this really has been the product of Lauren's hard work in putting these webinar series together. We've organised them in collaboration to mark World Prematurity Day. And unfortunately, Lauren is really unwell today and unfortunately has got a severe case of a lost voice. So I'm going to do my best to fill in for her, but she will be here and she will be participating in the chat and asking questions. So I'll really, in not too much time, I'll very shortly introduce our 3 guest speakers who we're delighted to have here today. But for now, as always with our webinars, if you could let us know who you are and where you're from and who you are and where you're dialing in from, that would be great. We've had over 200 registrations for this webinar series from across the world, and we've been delighted that our webinars have welcomed adults born preterm, parents of babies born preterm and healthcare professionals who have all come together to learn more about life after the NICU for adults born preterm. As always, please put any questions for the speakers in the chat and we will do our best to answer all of them at the end. We're anticipating maybe between about 30 to 45 minutes of our guest speakers, and then we'll go to questions and answers after that. It's all being recorded and it will all be posted on our YouTube channel for you to watch after the event in your own time. So I will now move over to the main event. So we have got perhaps a bit more of a traditional format today than our previous webinars. So there will be some slides which I'll shortly share and move through. But we're delighted to have a 3 guest speaker panel today to talk about preterm lung health and the BPD Collaborative. So we've got Professor Steve Abman, who's a professor of pediatrics at the University of Colorado and is a co-founder of the BPD Collaborative. So welcome, we're delighted to have you. We've got Dr. Sharon McGrath-Morrow, who is a pediatric pulmonologist at the Children's Hospital of Philadelphia and her research is into neonatal lung injury, and Professor Mike Calaso, who is Professor of Pediatrics at Johns Hopkins University and who studies the epidemiology of diseases like BPD. So we're really delighted to have you all. I'm going to turn my camera off now and share the slides, and I'll hand over to you. We're really, really grateful for you to be here today.
Well, great. Maybe I'll start as we wait for the slides. It's really such a pleasure to be here. And the 3 of us work together on many things, including the BPD Collaborative. So Sharon and Mike will give the guts of the talk today, but they've been wonderful collaborators and experts, mostly in respiratory medicine and pediatric pulmonary disease, and very engaged in folks who've been born preterm, regarding their NICU course and what happens following discharge during childhood. And then finally, adult onset disease or persistence of disease. And that's really the theme for today's talk. And what I'll do basically is I'm going to just sort of provide a little bit of an introduction, and then Sharon and Mike will go ahead and follow. But I just want to say briefly, as we'll talk a little bit more about the BPD Collaborative, but it was really formed because we really felt that that children who were born preterm were underserved, understudied. The management itself would be enhanced by developing collaborations between many of our NICUs across the North America and the country and now the world, but also by linking specialties, our neonatologists with pulmonologists, with cardiologists, with others, and that by enhancing communication, we could serve our patients and our families better. And then finally, it's been wonderful to get to know Lauren and this whole group here to really engage adults who are born preterm. And we're learning quite a bit of the importance of the problems and how to improve our communication. And I think that's sort of the theme that we'll be focusing on for today. But let me start with a brief introduction here. Next slide, please. And so this is the outline that we mentioned. I'll start with a couple of case presentations. Then we'll talk about preterm respiratory disease over the lifespan and improving lung health, and talk further about the BPD Collaborative in greater detail. And then we'll open it up for some panel discussion and questions. Next slide. So I really wanted to start by remembering that it was really in 1967, over 50 years ago, that Bill Northway, who is a radiologist, kind of put together the sequence of events and the changes in chest x-rays of premature babies who had acute lung disease, acute respiratory distress syndrome, which we traditionally called hyaline membrane disease, but really focused on the stages or evolution of disease in the NICU, focusing on the developments of some of the chronic problems, the prolonged respiratory disease. And as shown on this slide here, there's Bill. And we see an X-ray of a lung of a child who is born preterm with marked hyperinflation. The lungs themselves right next to it, in a child who died with severe BPD, show striking features of abnormal regions of the lungs. Some lungs are hyperinflated or have too much air in them. Others are not inflated enough. And that's sort of the problem if we talk about their care. And then finally, under the microscope, we see images of the lung showing that the lung itself hasn't grown sufficiently. Development has been arrested. We don't have enough of the small air sacules or alveoli. We also don't have enough blood vessels, or they're grown in a dysmorphic fashion. And that's what this slide is about. And we give Bill a lot of kudos for really establishing some of the foundational observations to think about chronic lung disease, which he labeled as bronchopulmonary dysplasia. Next slide. Well, over 50 years then, we had a nice little celebration. This was held at Stanford, and you can see Bill there, and we honored him, but also brought in a number of other folks to talk about BPD then and next, to really, over the 50 years plus, what's really evolved in terms of our understanding and interventions and how things have changed. And right behind him, we have Alan Jobe, who taught us so much about prematurity and how antenatal factors, maternal health, how the placenta work, how antenatal steroids can make a difference with acute lung disease. So many of these things were things that evolved after Bill's foundational work. And so much has been learned, and it's been really wonderful to see some dramatic improvements in neonatology over this time window. Next slide. And what's illustrated here is the time course of how things changed from Bill Northway's era, what's called the old BPD, and versus the new BPD, or current understanding of disease. This slide shows changes of different stages of lung development and how the embryo, the early fetus, the late fetus, the neonate, how changes in the airways, the air spaces, the blood vessels grow normally over time, as shown by these arrows here and showing the different stages. The different changes we see structurally that are shown in the green boxes. But I mostly want to show this, that one of the most dramatic changes has been the idea that now we're talking about babies who weren't as immature or so much later in gestation at 34 weeks, as highlighted in the old BPD box there. We're talking about babies now at 22, 23, 24 weeks, very preterm babies. And so with the increased survival and many of the achievements, we now have more and more issues with a greater focus on what happens later in the clinical course, especially regarding their lung disease. Next slide, please. And this kind of shows a couple of things. One thing is that we have this diagnosis of BPD, that although we have improved survival or better survival, and a number of the comorbidities of neonatology have gotten better, you can see that the BPD proportionality has not improved over time. And that's in the left panel there. About 40% or so of babies born before 29 weeks have this diagnosis of BPD, or chronic lung disease. And then you see on the right slide, one way of thinking about it is that there's been such an increase in the proportion of preterm babies born at 22 to 24, 26 weeks. And when we think about more severity of disease, or BPD itself, strongly associated with the improvements in survival, now we have to think about how can we better understand the lung disease itself. Next slide. And so what we found is sort of highlighted here. And that as over 50 years, we've learned that if you start at the top there, extreme prematurity really plays a significant role. Both postnatal factors, like the ventilators that are used to sustain support, the use of supplemental oxygen, other kinds of complications, clearly impact how the lung develops. There's some injury, there's developmental arrest, where that either leads to early death or recovery and regeneration. And we've learned over time, however, that antenatal factors, such as how the placenta works, diseases like chorioamnionitis, preeclampsia, maternal smoking, things like that play a major role as well. And so a number of folks are studying how antenatal factors and postnatal factors play into the origins of the disease. But we now have to think about what's really highlighted in the bottom red circle there. What about persistent respiratory disease? The need for recurrent hospitalizations after NICU discharge. How about adults who still are at risk for developing chronic lung disease? And how about other issues related to cardiovascular disease, such as pulmonary hypertension and other things that are noted there? And these are ongoing challenges. Next slide. So I want to just present two cases very briefly to you, because it shows the heterogeneity of clinical course and how these outcomes in many ways are not quite so predictable. And the first case is a delightful little girl, and you can see she was born somewhere around 26 weeks gestation. And in the upper left, she's on a ventilator. She has all sorts of lines and things going on with the mechanical ventilation, drugs to support her blood pressure, receiving inhaled nitric oxide for pulmonary hypertension, really required high levels of oxygen. In fact, there were many discussions by the team with the families and with each other saying, should we be sustaining our support here? Because she seemed to not respond very well for such a prolonged period. And was this going to be futile or not? But over time, with new ventilator strategies and persistence and cares, and having a team approach to care, the little girl then developed, she grew, she did well. She got off some of her supplemental needs. But here she has a tracheostomy in place, still requiring chronic ventilation. She even went home. She went home to a ranch in Nebraska where she was managed with home ventilation. Her parents took care of her. They had some local respiratory therapist engaged. And then she came back to us in the photograph on the right at time where it was time to take out the tracheostomy because of her recovery. Next slide. And this slide illustrates her. She was a ballerina, a cowgirl, a baseball player. She just graduated from high school this past year, she was an exceptional student. What a course. And from her tough start, we hardly would have guessed that she would have had this kind of clinical outcome, and it's been delightful. Next slide. And this other case I want to show you, unfortunately, the animation we can't work with here, but it's a college student who came to our laboratory at our medical center to do some research with us. And he told us that he was born preterm, and he had some shortness of breath still, even though he was he was about 20 years old at the time. And we decided to evaluate him. And what we found was he had some striking changes on his chest X-ray and a chest CAT scan that Sharon and Mike will talk about later, but they were abnormal. Hyperinflation of the lungs. And when we studied by lung function, the measurements we made were strikingly low. And I say this because this was a child who, as a newborn, did not require long ventilation, went home with a little bit of oxygen, but actually had a pretty good course early on, but had a history where his mom had prolonged premature rupture of membrane, and that was about it. So he was under the radar, in other words. Very little attention played to his respiratory course, even though he avoided a lot of activities as a young child and even growing into through adolescence. And certainly he has some changes there in his lung function and his course that really unmask the idea that we're really talking about disease that could persist into adulthood, that we as pediatricians need to link both the neonatal, the childhood, and the adult care to move forward into better understanding the course, the heterogeneity of outcomes, and how to better manage them. Next slide. And so it really told us, number one, the first case, how resilient the developing lung can be, how variable the outcomes can be beyond the degree of preterm birth itself. We need to understand better insights into lifespan issues, more than just how we diagnose BPD by oxygen needed 36 weeks corrected age. And we really need to develop interdisciplinary collaborations of the different specialties, but also to work more closely with our families, our patients across the lifespan, and better inform our providers on how to deal with the healthcare system for years to come. So with that, that's sort of my introduction, and I think we'll move on. And I think, Sharon, are you next then?
I'm next. Yes, thank you.
Okay.
So thank you, Steve. That was great overview. I'm going to talk a little bit about preterm respiratory disease across the lifespan. So next slide. So interestingly enough, preterm birth is actually pretty common. Close to 10% of all live births are premature, and that accounts for about 13 million preterm births in 2020. So about 13 million preterm births per year occur globally. And as you can see from this map, the prevalence varies a little bit in the United States and in the United Kingdom, about 10%. But there are hot spots. Areas in Africa have higher prevalence of preterm birth, same with India, also in Brazil. Next slide. So preterm births are the leading cause of death in children younger than 5 years of age. So about 1 million children across the world die each year due to preterm birth before 5 years of age. And it accounts for about 18% of all deaths in children under 5 years of age and about 35% of all deaths among newborns, defined as less than 28 days of age. Next slide. Even though we have a high prevalence of preterm birth globally, most children are considered later preterm births. And it's really the children that are less than 32 weeks that are most likely to have lung complications. So here again, it's just another figure looking at different areas of the world, prevalence of preterm birth by gestational age. And as you can see, the smallest groups are the children born less than 28 weeks. And then, but it's really the kids born less than 32 weeks and earlier that are the most likely to have chronic lung disease or to develop bronchopulmonary dysplasia. Next slide. But as Steve kind of alluded to, we've had great improvements in survival. It's been amazing. We've had, improvements in NICU care. We have incredible physicians, nurse practitioners, nurses, respiratory therapists, so that more and more of our extremely preterm children are surviving. However, particularly in the children who are the most preterm, often our survivors do have multiple medical conditions, including respiratory disease. And the most common, respiratory disease is bronchopulmonary dysplasia, and that can affect several million babies every year. It's the second most common pediatric respiratory condition after asthma. So this is not an uncommon condition. Next slide. So Mike and I looked at this, and we looked at in the United States, and we predicted about 360,000 children are born each year preterm in the US. And of these children, about 50,000 will go on to have some degree of bronchopulmonary dysplasia, depending upon how you define bronchopulmonary dysplasia. Another 12,000 will go home on home supplemental oxygen. About 200 will require home ventilators at home, as Steve showed us his patient who went home on a home ventilator, and probably up to about 66,000 children each year will go on to have childhood asthma or a form of childhood asthma due to their prematurity. So this is a really huge amount of respiratory disease that we can see in our preterm population. If you compare this to people with cystic fibrosis, in the United States, we have about 30 to 35,000 people of all ages with cystic fibrosis. And we have children born preterm, and very many of them will go on to have some form of chronic respiratory disease. What we don't know is what the burden of disease is in adult life, and we'll kind of talk about that a little bit. But as you can see on the right side, I'm just going to show you some of our patients at the Children's Hospital of Philadelphia. And so we have a BPD clinic, and we have many faces of chronic lung disease. As you can see, we have these twin boys who are doing very, very well. They're in kindergarten. We have this little girl who's learning how to play the piano. We have our twins down below who are now off oxygen and NG feeds. And we have a little guy who is still on a ventilator at home with his mother. Next slide. So, as Steve talked about, BPD is a developmental lung disease, and it's primarily caused by preterm birth. And it does affect the air spaces, or the alveolar spaces, the air exchange areas of the lung, the airways, and the blood vessels of the lung. But there's several definitions of BPD, and BPD and its severity is based on the level of respiratory support at 36 weeks. So as you can imagine, once these children go home from the NICU, it's hard to predict how they're going to do, because their BPD is based on what is occurring at 36 weeks corrected age during infancy. And so what we find is that some children who are thought to be severe BPD in the NICU may go on to do very, very well. And some of our children who may be mild BPD or not, diagnosed with BPD will go on to have some respiratory issues as they leave the NICU and throughout childhood. Next slide. So this is just another illustration of the different types of BPD and what we see in our outpatient clinics. So Mike is down at Johns Hopkins. I used to be down at Johns Hopkins. We started a registry down there. So looking at about 1,250 kids, most of the kids that we see in our clinic have severe BPD at 36 weeks gestation, corrected. However, many of them have mild or moderate BPD, and some were not diagnosed with BPD at all, but are coming to our clinic with chronic respiratory symptoms. The problem is, if only the children that have BPD are referred to the pulmonologist or the respirologist, there may be many children who are not really being followed and should be followed for their lung disease. And then we also see some of our older children and young adults who are presenting, and they may present with shortness of breath. They may present to their internists, and they never, through their medical records, the diagnosis of BPD doesn't follow them. So it's kind of lost after they leave the NICU or early in life. And so often the people who are taking care of these older teenagers or young adults really don't know much about their early history. And we think that that's a problem, and that's something that we want to address. Next slide. So what are the long-term effects of BPD? Well, we're talking primarily about the lungs, but there are other conditions such as neurodevelopment or behavioral outcomes, cardiovascular sequelae such as pulmonary hypertension. And we see that especially during the preschool years, there's an increased risk of rehospitalization. Next slide. So how does BPD affect the different parts of the lung. Well, earlier in life, we see a fair amount of what we call large airway disease or tracheomalacia. And that generally gets better with time, within the first couple of years of life. We also can see central apneas, and often these children are treated with caffeine to help with their breathing. And then the other thing that we see most commonly when these children, when preterm children are very young, is alveolar disease or gas exchange abnormalities. But over time, the expectation and what we see is most people who are born preterm will have catch-up growth and will come off supplemental oxygen. So the two types of issues that we see that can be persistent are the small airway disease, or the asthma type disease, and the vascular disease, which is the pulmonary hypertension disease. And we think that it's a small airway disease that increases the risk of early onset COPD, or chronic obstructive pulmonary disease in adult life. And the vascular disease or pulmonary hypertension, less commonly, but can also occur in later life. So kind of a resurgence. Next slide. So how do we kind of look at this conceptually? When we think about, on the right side, the small airways, we know that there's the bronchioles, and most people have healthy bronchioles. They're a certain diameter. There's no problem with breathing in and breathing out. People with asthma, or children with asthma in the middle one, they'll have inflammation inside of their airways. So even though their airways aren't anatomically smaller, the internal diameter of the airways is smaller. And so they're having obstruction or obstructive lung disease with their asthma. And then what we think about with the children with BPD, because they have the smaller number of air sacs or alveoli, as a result of that, their airways tend to be narrower, smaller, and that's more of a fixed airway obstruction. Next slide. I'm sorry, yeah, here we go. So when we look at the infant, we see on the far left, the small airway, probably because of the few alveoli. But over time, we have catch-up growth. And so
Oh, I think we might have a technical hitch. Just bear
that
with
is
us, everybody.
we prevent that from occurring? You know, are there some early interventions to allow the alveoli to grow maybe quicker so that we're less likely to have these narrowed airways? Next slide. So this is just a really, really interesting study that I wanted to share with you. And this was actually done in the United Kingdom, where they looked at children who were born preterm and they were school aged, between 7 and 12 years of life. And they did pulmonary function tests on these children. And they found that actually the majority of preterm children had normal lung function as the term controls, as you can see on the far right. But then they found that there were 4 other types of lung function changes that they found among these preterm children. Some of the children on the far left had reversible obstructive lung disease. Some of the children had fixed lung disease, kind of like their airways were small. Even if you gave them bronchodilators, it didn't open up. And so their obstructive lung disease was fixed. Other children had what we call a prism phenotype, in which the lungs were small. And even though they didn't really respond too much to bronchodilators, they still had a low FEV1, which is a marker of airway obstruction. And then the last type that they found were the children who had what we call dysynapses, in which their FEV1s, or the marker for airway obstruction, was normal, but their ratio, FEV1 to FVC ratio, was low. And so these were the 4 different kinds of abnormal lung function that they found in these formerly preterm children. But keep in mind, most of the children had normal lung function. Next slide. Another group of kids that are formerly preterm that are at risk for a lower lung function in later life are the children who had intrauterine growth restriction. And here was a study in which it's a small study. They only looked at 88 children. They were school age once again. They were less than 32 weeks gestation. And what they found was that kids that were preterm with IUGR or intrauterine growth restriction tended to have lower forced vital capacities and lower FEV1 than the children who were preterm who did not have intrauterine growth restriction. This goes to the fact that Steve brought up that placental abnormalities, which can cause IUGR, can impact long-term lung function in our preterm children. Next slide. This I'm bringing up because coming back to BPD as a developmental lung disease, we know that some people with BPD will go on to have chronic obstructive pulmonary disease. And this was an interesting study done on adults that had chronic obstructive pulmonary disease or COPD and those that didn't. And when they actually looked at the airway to total lung ratios, they found that the people who were not smokers who went on to get COPD tended to have a smaller ratio of airway to total lung. As you can see on the left-hand figure of the lung, versus the people who did not have COPD. Their airway to total lung ratios were larger. So this made us think, based on this study, that a lot of COPD is because of developmental changes, either that you're born with or possibly secondary to preterm birth. Next slide. So from this study, they found that abnormal lung development accounts for a large proportion of COPD risk among older adults. And so what we want to know is, do adults with BPD have similar abnormal lung development as found in COPD? And is prematurity alone a risk factor for abnormal lung development? Next slide. So we know that BPD can be associated with obstructive lung disease or small airway lung disease. That increases the risk of asthma, and it can increase cystic disease and severe BPD. However, it's unclear at this time whether or not this translates into an increased risk of COPD. And so we need to follow our children who are formerly preterm throughout childhood and into adulthood to see if we can identify those groups of children or people that are at risk for COPD. Next slide. So this is my last slide, but this is sort of my conceptual model. You know, who is it, and what are some of the factors that may contribute to the development of pre-COPD or COPD in formerly preterm children? Well, we know that intrauterine growth restriction is associated with lower lung function in later life. Steve did a really nice study a few years back showing that maternal smoking during pregnancy was associated with a higher risk of BPD. And of course, we have to consider gestational age, hyperoxia, exposure to positive pressure ventilation. That all contributes to the development of BPD. And then what are some of our modifiable factors? Perhaps, you know, poor caloric or nutritional intake doesn't allow the lung to have sufficient catch-up growth, which may contribute to small airway disease. Recurrent lower respiratory tract infections can affect the lungs so that you may be more likely to have cumulative damage over time. Environmental factors such as smoke exposure and air pollution. And this can all lead to abnormalities in the lung and small airways, possibly being factors for pre-COPD or COPD. Next slide. So Mike Colasso is now going to talk a little bit about how we can improve lung health in our formerly preterm children.
Thank you, Sharon. This is the third part of the talk, and you know, it's something that Lauren asked us to put together as hopefully a summary of what we think the evidence shows so far in improving lung health. Next slide, please. So to begin with, I think this is what we and I think other clinicians are trying to improve. We know that, you know, unfortunately, people who are born preterm frequently have lower lung function than people who are born full term. And you can see sort of a trajectory here of lung function throughout the lifespan. The dotted red line is for people who are born preterm, and the solid blue line is for people who are born full term. Lung function generally reaches a maximum or a peak in the early 20s and then declines from there on in. And you can see if you were born preterm and you reach a lower peak, you might then, through natural decline, reach an earlier or a younger threshold for having lung disease as an adult. And so what we hope to do is to help people who are born preterm achieve a trajectory that is more similar to the general population, and thus, preserve lung function into adulthood. Next slide, please. So some concrete things. So one is, accessing medical care. I think it's important to work with your primary care physicians, your general practitioners, and subspecialists when necessary. And sometimes it involves educating providers as well, because we certainly don't know everything. So making sure that they're aware that lung disease associated with prematurity, as Sharon and Steve have both pointed out, can last a lifetime. It's potentially a chronic diagnosis. And then, accordingly, making sure it's documented in the medical record, either prematurity or bronchopulmonary dysplasia. At least in the United States, there are billing codes for both that can remain with the medical record to allow the diagnoses to be tracked from provider to provider or healthcare institution to healthcare institution. You should also be aware that there are no guidelines for what testing we should do to monitor how lung disease progresses or if there are complications. There are no guidelines for who should see respiratory subspecialists and how often, or what therapies are best practice. Again, this is very much an evolving area of research and study. Next slide, please. So some testing to at least consider throughout childhood and adult life. The most basic test is pulmonary function testing or spirometry, which some of you may have had done, which is breathing in and out of a tube to measure lung volumes and flow. Typically, that can be done from about age 6 years and onward. Particularly, this should be considered if you have any wheezing, shortness of breath, or exercise intolerance. It's again unclear how often this test should be repeated to follow clinical progress. As Steve alluded to in the beginning part of his talk, people who are born preterm are also potentially subject to vascular complications within the lung due to limited blood vessel growth, and so there's a concern for pulmonary hypertension. There are some studies which have shown that some of this pulmonary hypertension can persist into young adulthood, as Sharon mentioned. And so if there's a concern for this, an echocardiogram could be considered. Overnight sleep studies should be considered if there is any concern for obstructive sleep apnea, or if someone requires supplemental oxygen, non-invasive ventilation, or positive pressure ventilation. Again, to help diagnose sleep disorder breathing and hopefully initiate appropriate therapies when warranted. Imaging, certainly we don't tend to do routine imaging on most of our patients with preterm lung disease, but certainly chest x-rays and CTs can be considered, particularly if there's any concern for cystic disease, recurrent infections, or other complications. Bronchoscopy, either by respirologists or pulmonologists, or laryngoscopy by ENT or otolaryngologists, can be considered for large upper airway or large airway concerns like malacia, or if there are chronic infections. Next slide, please. So other things to keep one's lungs healthy include avoiding air pollution. We know that air pollution can make a lot of many lung diseases worse, including bronchopulmonary dysplasia. Sharon and I have done several studies in this area, and we've documented, at least within infants and young children, secondhand smoke, vape emissions, that is, secondhand exposure to e-cigarette or vaping devices, indoor combustion, such as gas stoves, traffic-related air pollution, and wildfires can all have adverse effects on either acute care use, such as going to an emergency department, or chronic symptoms such as wheezing and or albuterol use. So accordingly, we advise our patients and families to avoid smoking or vaping around their children, and certainly adults should do that as well. To use a vent fan when cooking, especially with gas stoves, and to limit time outside on poor air quality days whenever possible. Next slide, please. Also, part and parcel of this is avoiding infections, because even common respiratory viral infections such as rhinovirus, the common cold, can lead to more severe illness in people with preterm lung disease. We know, and Sharon has already alluded to the fact that infants and young children have an increased risk of hospital admission. And in studies that we've done in single center manner as well as multi-center study in the United States, daycare for young children is associated with a higher risk of emergency department visits and hospital admissions, probably about threefold. So we counsel families, if their circumstances allow, to avoid those exposures if possible. But certainly we understand that, families, may have to send children to daycare in order to work. We also recommend getting any vaccinations that you're eligible for. For everyone over the age of 6 months, this includes influenza vaccinations. Currently, for respiratory syncytial virus, this includes adults who have lung disease, as well as there are some antibody therapies for infants and young children who are at high risk. COVID-19 vaccinations and boosters, and pneumococcal vaccinations and boosters for adults, as well as children who have been maybe more vulnerable. Next slide, please. Good nutrition is also important. In many of our patients, particularly during infancy and early childhood, there's a high risk of poor growth. Why? Frequently, at being born preterm, they have needs for catch-up growth and healing. Sometimes they have poor oral intake due to feeding difficulties. And sometimes if they're, just plain tachypnic, that is breathing very, very rapidly, they may use extra calories to breathe rather than to grow. However, later, abnormal weight gain, associated with a high body mass index or obesity after NICU discharge can be associated with airway dysynapsis, so precursors to COPD potentially. We think that, at least during childhood and adolescence, height may be a better marker for lung growth than weight, and so that should be followed more closely. And during adulthood, we're not quite sure what the best measure for following nutritional status is in terms of lung health is. And so we certainly recommend discussing your nutritional status with your health provider during, routine visits. Next slide, please. So I'm going to turn it over here back to Steve for a few closing remarks on the BPD Collaborative. Steve?
Yeah, thanks, Michael. So next slide, please. So what we recognized, over a dozen years ago was that we still had so many open questions of how to think about our kids who are born preterm in terms of how to best manage their care with the changing perspective, the evolution of our understanding of how the lung and the heart develop, how disruptions lead to long-standing issues. And because we're seeing especially severe forms of chronic lung disease still within the NICU, that is within the, at the time of 36 weeks, as Sharon mentioned, when we make a formal diagnosis of BPD, we had a number of kids who still remained on invasive ventilation, on a strikingly large number of pharmacologic agents or drugs to treat their lungs and related conditions. And we're seeing, begin to recognize more and more problems with pulmonary hypertension, where the blood vessels in the lung are abnormal, where the right heart is under stress and strain. And so it's really understanding the heart, the lung, the blood vessels. We really wanted to get a group of folks together to focus on how could we better manage these kids. When we first got together, we had so many different ideas, and we spoke with folks from a number of different centers, all with different care strategies. And so we figured that we could start by learning from each other. We had a lot of meetings and formed this collaborative group. And it's grown from just a handful of sites, 7 centers initially, to now we have about 47 sites, including a few that are international. And what's been really, really exciting about it is that it really is truly interprofessional. And that is, we have nurses and respiratory therapists and, all the different specialists within pediatrics, nutritionists, many different folks who are engaged in these kids and with different kinds of wisdom and pieces of experience that could help inform our group. So it started with just a lot of different discussions, case presentations, ideas presented. We developed some project to do a little bit of identifying some of the gaps in our care and understanding. And from that, we developed a large number of working groups that had focused research projects, ranging from issues related to the drugs, to how to optimize the use of the ventilator, to nutrition, to patient advocacy now is one of our groups, and many, many others. And so it's been really very exciting. Every year we have a meeting in Philadelphia that's incorporated with a meeting through the Children's Hospital of Philadelphia on chronic lung disease, which we link with the BPD Collaborative. Since we're like peas in the same pod, all interested in the same kind of issues and problems and the same folks for a large extent. And when you enter the room now, a dozen years later, the vibe in the room is unbelievable. High energy, incredible enthusiasm, a wonderful sharing of wisdom and experience, as we mentioned. And new ideas evolve from this. And from that, we've had, over 25 to 30 publications from this group, which have really stimulated the field and have come up with some new insights and some new information that will help us better care for our kids and improve outcomes over the years to follow. And really linking it now with, adult-related issues of having been born preterm is our most recent, I think, targeted area. And that's why working with this group, the adult preemies group and others, 99 NICU and other folks, we could really come together with some new ways of getting the word out of how to think about disease, how to make sure folks know how to navigate complicated healthcare systems, and that we can start to do some of the clinical research that's necessary to get smarter about doing the right things. And so really that's what the BPD Collaborative is about. And it's been wonderful that we've gotten in touch with Lauren and with others. And we're looking forward to ongoing work, long ones, even when this webinar is over. This is just the starting point of getting us to think together, work together. So thank you very much for this opportunity.
Thank you very much. Really excellent panel of speakers, lots of interesting journeys as well to share. There's a few things in the chat, so I'll just kind of run through them now. One of the first questions is from Angela, who is from the US, so from the USA, I think. And she, you might be able to see this in the chat. She's got a similar question, I think, to me, but she said that she's always had issues like shortness of breath, feeling starved of oxygen, chest tightness, needing air blowing on her face while she was sleeping. She doesn't have BPD in her records from the NICU, but it does mention apnea. She's had tests that have been inconclusive. Doctors always say it could be asthma, but for years she's wondered if it's BPD. How does she go about getting an assessment for that? Or does it not really matter in terms of how your treatment is provided? So I don't know who wants to jump in with that to begin with.
Steve, do you want to take a first stab at it and then we can add on?
Well, I think, you know, we use this term BPD, and we kind of overuse it, as so nicely highlighted by Sharon and Mike, about where really there are a number of breathing issues that are engaged and involved. So certainly a full evaluation with those kinds of signs and problems is certainly warranted. And I think this is what we need to tackle, that it's not just a question of asthma. It's not just a question of once having had BPD, now it's gone. And so I think that's the complexity of the issue. But from the features that Sharon highlighted, maybe I'll go next to Sharon to go through the kinds of things that we would be concerned about, and then finally how to navigate a healthcare system that often isn't user-friendly. And certainly we have too many providers who are not aware of even asking the simple question about were you born preterm? And I know that a number of you have already been engaged in this kind of area as for advocacy. And we have Michelle Kelly here also, who's been prominent, beautiful writing about the multitude of things we should be asking about, even if we're not specialists in lung disease. So Sharon, anyway, take it away.
Yeah, I think we're really trying to partner with our primary care physicians, our nurse practitioners, our PAs, because there's only a certain amount of pulmonologists and respirologists. And so I think if we can put together some guidelines, if you're born preterm, we think you should have pulmonary function test at 5 to 7 years of age. We should get it, we should see where you are. Even if you do have normal lung function, I think you should have that repeated again at the age of 8 to 12, because sometimes we can see a decline in lung function. We also know that there's certain modifiable factors after you leave the NICU. I mean, I think it's very, very important to realize that if you're born preterm, at least for a while, and maybe your whole life, you're going to have some susceptibilities to having more severe respiratory illnesses when you get common, viruses. And it's really the respiratory viruses that can really be problematic early in life, because it can impact your ability to have normal catch-up growth. And it also can cause a chronic inflammatory sort of condition in the lungs, which, you can, many of the symptoms can resemble asthma, but not all of the asthma medications may be effective for the symptoms that you're describing. And, so as I was trying to show with the different kinds of pulmonary function tests that people who are born preterm can have, some are responsive to things like albuterol or inhaled corticosteroids, but some kids aren't. They may be more responsive to other medications, or it may be that we just need to follow lung function carefully. As Mike can chime in, but Mike was showing that graph that by about 21 years of age, you really reach your peak lung function. And so if we know at age 5 or 6 that your lung function isn't really on the trajectory we think it should be on, what can we do to improve that trajectory? But I think we have to start early. And that's why it's so important. Even if you're not having a lot of symptoms early on, we have to kind of keep an eye on lung function of children, because it can be a kind of a silent sort of symptoms initially. And then as the kids get older, as you become an adolescent, you go through another growth spurt. That may be when you start noticing more of the respiratory symptoms. So Mike, I don't know if you have anything to add.
I just have one last thought to add, just to keep in mind. We've been talking a lot about, bronchopulmonary dysplasia. And I think it's important to recognize that it's a diagnosis that's made on a definition at a specific point in time, when someone is 36 weeks gestational age after birth. And, it's, when we think about it, and if you stop to think about it for a second, it's kind of ludicrous that, this one time point in your life at, when you're an infant, sort of defines, quote unquote, the respiratory disease you have for the remainder of your life. And so even if you don't have a diagnosis of BPD on your chart, or if you do, it doesn't necessarily mean that what you're experiencing at age 15, at age 20, at age 30, age 45, and beyond necessarily, is correlated with whatever was written down in your chart, when you're an infant. So, I think, an important thing to, review with your provider is people with preterm history, are more susceptible to a variety of different, cardiac conditions, respiratory conditions, etc. And, it's something that they need to, think a little bit more or be a little more thoughtful about when they're, trying to figure out helping you diagnose, what's going on with you, as well as treatment options.
Yeah, if I
you.
can, I wanted to just highlight that too, because that's so important. Don't get stuck on this binary yes or no BPD thing. And prematurity itself is strongly associated, as Michael mentioned. And it's such a wide variety of courses. But the important thing is that a number of our providers who may not be pulmonologists, or they may be pulmonologists, the primary care folks, they get stuck on this idea just as we used to, I think, to a large extent, right? And so if they raise this question of yes or no BPD, I think it's so vital to emphasize what Michael just said, that regardless of that, these are things that should be pursued, that there are early origins of adult lung disease, and don't get stuck on the BPD yes or no is what I would kindly tell our providers, because even having been to medical school and et cetera, it's just not a way of thinking about it. And that's what we're trying to overcome. And it'll help you navigate the healthcare system a little more effectively. The second thing I just want to say really briefly is this. Part of the reason why it's so important is this, that the adults who take care of obstructive lung disease known as COPD, chronic obstructive pulmonary disease, have realized that's also a big heterogeneous collection of things. And so if you're having shortness of breath, respiratory symptoms at all, those kinds of things, they know that there's another category that's called pre-COPD that links with this idea that, stuff happens before birth, stuff happens that's there. Let's not underestimate it and under-recognize and under-treat. And the reason why that's important is some exciting recent data that as we're learning more and more of how to treat older adults, even those who weren't born preterm, but older adults with COPD, some of these medications and novel biologic therapies have been shown to be pretty effective and pretty good in stabilizing breathing problems, improving quality of life. What's really interesting is if recognized early, some of these medications, if started earlier, make a difference in terms of having acute exacerbations, we call it. That's when you have acute on chronic stuff. You get that virus and you're suddenly sicker and sicker, or something else is going on, an exposure or something. That being on those medicines, being aware of this possibility, that does improve the clinical course. And that's sort of newer data, but it's so exciting. But a lot of the research is from when you're adult already. We're wondering, from what Sharon said, gosh, if we knew that when they were 6 or 8 years old, could we start to think about what kind of medicines should we bring down to earlier ages and to monitor closely? Will we see even enhanced outcomes longer term beyond just the acute short-term wheezing or cough that might go away at some point? Could we attenuate those, improve longer-term outcomes on top of just giving better care and feeling better as well? So anyway, so that's why this is so exciting to link the fields, but don't be shy of talking to your healthcare providers that it's not a yes or no kind of thing. And being born preterm, they need to be aware of the implications and stuff.
Yeah, and I think based on something that Sharon was saying in her part of her talk about how a lot of the people that you're seeing don't have a definite diagnosis or didn't have a diagnosis of BPD, linking back to what Angela has said, but also to what Dr. Johansson has said in the chat actually is, who should we, because there's lots of neonatal providers on the webinar, who should we be following if it's not just, I don't mean just, but if it's not people who've got a diagnosis of BPD as well, who should we be following up so that we can start those things earlier? And should there be something like a grown-up clinic for ex-preterms, I think is what's in the chat. So yeah, maybe last final thoughts before we're going to have to sadly draw to a close. But yeah, last comments, please.
Yeah, I think we're really reaching out to our adult colleagues, and we have quite a few adult colleagues who are very interested in formerly preterm children because they're seeing them. Just last week, I had one of our med peds people come up to me and say, I have this 36-year-old who has horrible lung function and is requiring all this oxygen. And oh, by the way, we just found out that he was born preterm. You know, he was a 26-weeker, but that was nowhere in his record, you know? And so, you know, getting back to what Steve's saying is if we can identify these children after they leave the NICU and follow them throughout childhood and adolescence, I think we can get a feel for how to intervene to really modify some of the risk factors that could make their lung function, you know, not as good. And then partnering with our adult colleagues is really going to be important. Somebody in the chat said, you know, should we have something like have the congenital cardiac disease type of protocols or guidelines? And I think absolutely, if you're born preterm, it's up to us. We have to put together guidelines to help help the PCPs and the pediatricians and the internists to sort of help them in terms of tracking, you know, lung function and picking up early kids that may be at risk for having more adverse outcomes as they age.
Yeah, I just want to add that that's what Michael and Sharon are so thoughtfully leading in terms of the BPD Collaborative, is to get folks together. We have some adult colleagues, as Sharon mentioned, to really optimize this, develop some guidelines as a starting point. We have to gain more knowledge from research, absolutely, but having a starting point of how to not undertreat, under-recognize. And I think having that impact, even before we have more data per se on a specific intervention, is so vital. The other piece, though, is as adults who are born preterm, we as pediatricians are really into prevention. We're into really improving quality of life in different ways. And we really feel that do not accept the symptoms that you have without pursuing them with your healthcare provider. In other words, I'm like the medical student, the student in our lab who now was finishing medical school, by the way. He was so accepting of exercise intolerance. He wouldn't go skiing. He wouldn't go up in the mountains. He just in gym class, we would find other activities. And that was a lifelong pattern. And we would encourage that, no, our goals is to have highest quality of life, to pursue and investigate what's going on, and to find ways of managing that to really enhance all of these things. So don't accept the symptoms you have without deeply inquiring and pursuing them. And again, navigating the system's tough, but go for it. Okay, so thanks.
Thank you very much to everybody. I think that we probably have to wrap up now because we're at our end time. But just to thank everybody again for attending. So thank you to Professor Abman, for Dr. Sharon McGrath-Morrow, and for Professor Colascio, to Lauren from the Adult Preemie Advocacy Network for putting together this fourth webinar. And I've just shared a link or I've just shared a screen actually, just to show that our final fifth webinar in the series will be on next Wednesday, the 27th of November at 10 o'clock in GMT time. And that's going to be looking at the Periscope project and an insight into what matters for adults born preterm with Rachel Collum from the Northern Neonatal Network Parent Advisory Group. So thank you again, everyone, for being here. We will upload this to the YouTube channel when it's been formatted. And yeah, thank you everybody for your time, and thanks again to all of our speakers.